Hello guys, I hope you're well. So today we're going through some different points in the Gphc exam that I think are crucial to understand when it comes to the exam. Now, a very important point is there's a drug family called SGLT2 inhibitors. These SGLT2 inhibitors are drugs that are important because they are anti-diabetics, but they are also used for diabetes with cardiovascular disease. So that's point number one. Now, with SGLT2 inhibitors, not all SGLT2 inhibitors are licensed for heart failure. That's also a crucial point. So when it comes to SGLT2 inhibitors, the ones that are licensed for heart failure would be Dapaglifozin and Dapaglifozin. Dapaglifozin cannot be used for heart failure. That is the first point we need to understand. Now, when we look at cardiovascular conditions, if you have heart failure with reduced ejection fraction, the mnemonic you can give is for BAMs. So beta blockers, ACE inhibitors, mineralocorticoid antagonists like spironolactone, and SGLT2 inhibitors. Now, after you've exhausted those options and after those options have been used up, then you can give ivabradine. So ivabradine can be given in heart failure in sinus rhythm. So and with those that have higher than 75 beats per minute and have a reduced ejection fraction of less than 35%. That's a crucial point. Now, another important point that they always ask about is which of the following beta blockers is licensed for heart failure, or which beta blocker can be given to reduce nightmares, or which beta blocker can be given if someone has asthma. So you need to know the lipid-soluble beta blockers, the cardioselective beta blockers, all the different beta blockers that will cause less nightmares, etc., etc. Now, and also another important point is knowing the serum ranges for the high-risk drugs. So you need to know the serum range for lithium, which is 0.421, and that generally depends on the indication as well, because lithium is generally used for bipolar disorder. Now, you need to know the serum ranges for carbamazepine, for digoxin, and you need to understand a lot of the thyroid medication has a lot of important points you have to know. Like, for example, levothyroxine is used for hypothyroidism, which is Hashimoto's disease. Carbimazole is given for Graves' disease, which is hypothyroidism, and that's a very, very important point to know. And yeah, generally, when we look at sort of, let's say, amiodarone has four main ADRs we have to know. So amiodarone has pulmonary toxicity, ocular toxicity, hepatotoxicity, and generally, these are the ADRs for amiodarone. Now, when you think of pulmonary toxicity, how will they present that to you in a question? So pulmonary toxicity generally would present as dry cough, kind of like shortness of breath, and that's how you would see pulmonary toxicity. It's not like they're going to give you a question and they're going to tell you, oh, amiodarone causes pulmonary toxicity or stuff like that. So also you need to know PPIs as well. So PPIs can cause hypomagnesemia, and that's important to know. Also, they can cause systemic lupus erythematosus. They can also cause C. difficile, so Clostridium difficile infection. You also need to know the antibiotics that can cause C. diff and the antibiotics that can treat C. difficile. So a very, very crucial point that they love to ask is, you know, which drugs will affect the INR of warfarin, right? So that's an important point. Or which drugs will affect the efficacy of warfarin? Which drugs will affect the effectiveness of warfarin? So essentially, just to sum it up and give you the recipe, if you have a CYP inducer will reduce INR of warfarin. A CYP inhibitor will increase the INR of warfarin. So if you increase the efficacy or effectiveness of warfarin, you've decreased the INR. If you've decreased the effectiveness and efficacy of warfarin, you've increased the INR, and that's a crucial point to understand. So another point about antibiotics is you have drugs like metronidazole. So metronidazole cannot be given with alcohol, and you should separate alcohol and metronidazole by 2 days. So that's 48 hours, and that's a crucial point to understand. Now, why? Because If you don't separate the two, you can have something called a disulfiram-like reaction. A disulfiram-like reaction is basically a reaction in which the patient will vomit. So the patient will vomit if they take metronidazole and alcohol, and that's what disulfiram-like reaction is. Now, disulfiram is also a drug that can be dispensed, so it's an actual licensed drug as far as I'm aware. Now, if we quickly just see on my notes what to go through. Also, they love to ask about patches. So here there's a question here that says, do GTN patches cause tolerance? So according to my notes, it says yes, and they can leave patch off overnight. So that's quite interesting. So a lot of the questions in the exams ask about patches, ask about different formulations. For example, for some reason, they always generally ask about brand prescribing. So generally, some drugs need to be brand prescribed. For example, theophylline. So theophylline needs to be brand prescribed because of pharmacokinetic differences. So modified release theophylline has to be brand prescribed because if you give different brands, you can have different pharmacokinetics, and that's a very important point. Now, here I have a question: why should you avoid abrupt withdrawal for nitrates? And it says it's because it can have vasoconstrictor effects and cause rebound angina, and that's a crucial point. Now, also I have a mention in my notes about gynecomastia and spironolactone. So spironolactone can cause gynecomastia. That's very, very important. Also, we need to mention the fact that antipsychotics generally can cause hyperprolactinemia. So if you have hyperprolactinemia, that means you have galactorrhea, and that means you have breast enlargement. So that's very, very important. So whenever you have high prolactin levels could lead to breast milk production, even for men, and it can lead to breast enlargement as well. So galactorrhea is the essentially formation of breast milk in the breasts for men as well, and that's what they mean by breast milk formation or breast enlargement or stuff like that. So which diuretic is preferred with digoxin? Well, you can give potassium-sparing diuretics. So potassium-sparing diuretics are preferred because you don't really. So because spironolactone can cause hyperkalemia, you're not worried about giving potassium supplements when you, for example, give a loop diuretic or another diuretic that will cause hyperkalemia, because a lot of diuretics, they will cause hyperkalemia. However, because you're worried about cardiac arrhythmias, you're worried about torsades, the points, generally if you give furosemide or a loop diuretic that will cause hyperkalemia, you would generally give a potassium supplement with it. So that's very, very important. Now, potassium supplement can be something like Sando-K, very, very crucial point. Here I have, what's the target warfarin value for recurrent DVT? So apparently it's 3.5. I'll need to confirm that because I'm not sure. So here it says the target warfarin value, so the warfarin INR for recurrent DVT is 3.5. I'll need to just verify that because I'm not sure. Here it says, there's a question about a female going to A&E and they have a diagnosis of a DVT and the patient is started on warfarin. She takes no regular medication apart from the combined pill. How long will she likely need to take warfarin for? So it says 12 weeks. So then on the notes it says, if it's provoked DVT, then she needs to take it for 3 months. If it's unprovoked, then it's 3 months plus. If it's an isolated coughing DVT, then it's 6 weeks. So that's a very, very crucial difference. So knowing information about warfarin definitely will go a long way in the exam. Knowing the target INR levels will go a long way. Knowing that you don't need to halt green vegetable intake, rather you need to keep it constant, is very, very crucial as well. And that's a very, very important point. When we're studying, people generally think you need to just halt all types of green leafy vegetables, but you really don't. Anyway, so which foods and drink can you not take with fexofenadine? That's orange juice, apple juice, or fruits. Which juice can you not take with flodipine? Apparently that's grapefruit juice. So yeah, so generally students will get confused between which juices you can or can't take with medication. Now, generally with grapefruit juice should not be taken with statins, should not be taken with amlodipine, should not be taken with amiodarone. There's three main drugs that you can't, take grapefruit juice with, right? Now, also another important point they ask about is tyramine-rich foods. So a lot of times they'll ask about monoamine oxidase inhibitors and tyramine-rich foods. So the first question is, which foods have a lot of tyramine? So the foods that have a lot of tyramine would be mature cheese, aged wines, meats, salami, stuff like that. Now, you need to know that if you take tyramine-rich foods with some monoamine oxidase inhibitors, then that will lead to a hypertensive crisis. And that's a very, very important point to know. Now, why should statins be avoided in intracerebral hemorrhage? It's because it increases the risk of hemorrhagic stroke, and that's a very, very important point. Now, also to mention that sometimes when babies are born, sometimes you can give vitamin K. So you can give an intramuscular vitamin K or oral vitamin K. Now, why? Because warfarin can cause for babies intracerebral hemorrhage. So the vitamin K will sort of prevent that or reduce that. And that's very, very important. Now, another important point is rivaroxaban. So rivaroxaban 15 milligrams and 20 milligrams should be given with food. Now, why? Because there is better absorption and it reduces bleeding events. That's very, very important. Now, a lot of times students will ask me about DOAC doses, and they'll ask me, do I need to know the doses for DOACs for certain indications? Now, for most drugs you don't. So for most, if not all drugs, you don't. However, for DOACs, or even sometimes nitrates, there is a recurring theme where they may ask you which drug is taken twice daily, which drug is taken once daily, and that differs. For example, it's a bit like long-acting insulins. So long-acting insulins, even though they're long-acting, some of them are taken once or twice daily. So for example, you have something called a basal bolus regimen, and a bolus regimen is something you give before meals. So something you give as a big lump mass, and you just inject it, right? So, but the basal is more to do with you're trying to mimic the endogenous insulin secretion of the body, and you're trying to give a steady state throughout the day. And that's the difference between basal and bolus. So basal is supposed to mimic the body's natural secretion, and bolus is supposed to just be one shot, a big amount, and it's given before meals. And that's very, very important to know. Here I have which drugs interact with simvastatin, and therefore maximum 20 milligrams overnight. So you have the mnemonic of VAD. So VAD is verapamil, amlodipine, amiodarone, ranitidine, and diltiazem. So VAD are the drugs that you shouldn't give more than 20 milligrams of simvastatin for. Now, if I was to ask you guys, the viewers, what's an advantage of warfarins over DOACs? What do you guys think? So I want you guys to think about that. So what's the advantage of warfarin over DOACs? So when I'm thinking about that, a crucial point that comes to mind is warfarin can be given under renal impairment. However, you need to monitor INR more frequently. That's the first point you need to know, okay? So with DOACs, most DOACs you cannot give if the eGFR is less than 15 milliliters per minute, right? But the only exception would be dapagliflozin. Dapagliflozin you cannot give if the eGFR is less than 30 milliliters per minute. So it's a bit similar to metformin. Now, edoxaban is, you can't give edoxaban if the eGFR is less than 15 as well. So that's a very, very crucial point as well. So, can you give low molecular weight heparins in pregnancy and breastfeeding? Yes, you can. That's a very, very important point. So here it says orange, just giving advice, improves them. Okay, so I have another note. What's the antidote for dabigatran? So the antidote for dabigatran is idursulfimab. This is the antidote for dabigatran. I need to know that. And also, why should ACE inhibitors be avoided during dialysis? That's because they can worsen renal function. That makes sense. Side effects of GTN, that's flushing, hypertension, headache as well. So I think it is very important to discuss Viagra. So Viagra is sildenafil, right? So sildenafil works by releasing nitric oxide in the penile tissue. That's why you cannot give Viagra with the nitrates. So you cannot give Viagra with nitrates because they will cause dilatation and they will cause too much of it. It's a bit like you wouldn't give a lot of decongestant nasal spray, so you wouldn't give decongestant nasal spray for more than a week. Now why? Because you can cause rebound hypertension, and that's a very, very important point to understand. So how do you prevent nitrate tolerance? You have a nitrate-free period and you give the next dose after 8 hours. So that's a very, very important point. So it's a bit like the pill-free period. So the pill-free period is basically where you take, you give the contraceptive pill for 21 days, then you take a whole week of pill-free period. And that's very, very important. So you have 7 days where you don't give a pill. So you need to understand that. So with the contraceptives, you generally have a 28-day treatment. So you give 21 days of treatment, then you have 7 days of pill-free period. It's a bit similar to nitrate tolerance. So you have a nitrate-free period where you give the next dose after 8 hours. That's very, very important. So now let's talk about this. So if you have hypertension with type 2 diabetes, why do you generally not give ACE inhibitors to African Caribbeans? Now, according to the NICE CKS, you would give ARBs, or losartan, to African Caribbeans. It's preferred. I'm not sure exactly why. It could be something linked to genetics, it could be something linked to renin levels, but I'm not too sure, and I don't want to lie to you guys. Also, which antihypertensives are suitable in pregnancy? So the antihypertensive suitable in pregnancy would be labetalol, methyldopa. So labetalol, modified release nifedipine, and methyldopa. These are the 3 drugs that are suitable as antihypertensives in pregnancy. What drug can be given for subarachnoid hemorrhage? That's nimodipine, right? And this is very, very important to understand. Okay, so I have notes here which say which drug has a MHRA warning of calciphylaxis. Okay, so generally when it comes to calciphylaxis, warfarin has a MHRA warning of calciphylaxis. So that just means, what is calciphylaxis? So calciphylaxis is a rash that is caused by warfarin, but it's just the MHRA warning. So it's not like a penicillin rash, although they are both rashes. So yeah, you just need to know that it's just the MHRA warning. Which statin can be taken at any time of the day? That's atorvastatin and rosuvastatin. So simvastatin should only be taken in the evening. Atorvastatin and rosuvastatin can be taken in the morning or evening. So thiazide diuretics are cautioned in diabetes and gout. Now why? Because thiazide diuretics like indapamide or benzoyl can cause hyperglycemia, hyperuricemia, and hypokalemia, and that's why they are cautioned in diabetes and gout, and that's very, very important. Now, which medication can cause blue like urine? You have triamterene and you have TCAs. So you have nortriptyline and amitriptyline. So that's very, very important. So what do you monitor for statins? Now, this is very, very important. So if you have a patient scenario where the patient has muscle pain symptoms, then you need to measure creatine kinase. So creatine kinase is important to measure. And why? So if you have any muscle breakdown, any muscle pain symptoms, you'll measure creatine kinase levels. So the reference range for creatine kinase is greater than or equal to 5 times the upper limit of normal. So if the creatine kinase level for a patient is greater than or equal to 5 times the upper limit of normal, then you would retake the CK levels a week after. Now, if the CK levels are still greater than or equal to 5 times the upper limit of normal, then that means you have proved that the muscle breakdown symptoms are because of the statin. And for that reason, you would not initiate a new statin, or you would pause the statin, right? Now, as well as that, you can measure the ALT or AST levels. Now, it would be logical to say that for a lot of drugs that are used in chronic conditions, you need to treat the thyroid issue before you initiate it. So you need to treat hypothyroidism, for example, before giving a statin, right? For some statins like rosuvastatin, you need to treat hypothyroidism before you initiate it. And this is a crucial point to understand. So with hypothyroidism, with statins, especially rosuvastatin, you have to treat hypothyroidism before you initiate it. And this is a crucial point to understand. Now, I've had this question being asked before. So, okay. So, if statins can cause hyperglycemia, why do we give statins for diabetes? Now, the reason why we can give statins for diabetes is because even though they can cause hyperglycemia, even though they can lead to diabetes, their vascular benefit, their benefit cardiovascularly outweighs the risk of them causing diabetes. And this is a very crucial point to understand. So understanding that statins benefit on vascular health, or statins' vascular benefit outweighs the risk of causing diabetes. And that's very crucial to understand. Now, when we look at beta blockers, so with beta blockers, generally beta blockers, some of them can be used as antiarrhythmics. So the one example of that is sotalol. So sotalol can cause QT interval prolongation, and this is very crucial to understand. So sotalol is used as an antiarrhythmic compared to other beta blockers, and that's very crucial to understand. So yeah, okay. So now, with dual antiplatelets, a lot of times through cardiovascular chapters, there is a lot of mention of dual antiplatelet therapy. So what exactly is dual antiplatelet therapy? So dual antiplatelet therapy can generally be aspirin with clopidogrel, right? That's generally what you would give. So generally you would give aspirin 300 milligrams with clopidogrel or something like that. But let me individual like that. Thank you so much.